Good afternoon all. I'm going to look at what is the Diabetes Think Check Act. This project started from very humble beginnings of a few interested clinicians involved in diabetes care that realised that inpatient care needs to improve. We've been very heavily supported by Healthcare Improvement Scotland over the last 3 to 4 years, and we now have a brand. We have the Diabetes Think Check brand, which you can see the logo in the bottom right corner of all these slides. And that's been a very powerful achievement within the project because it advertises diabetes. We have several resources which we can show you. So the aim of the Diabetes Think Check Act programme is to improve the quality of care for patients who are admitted with their diabetes to hospital as opposed to those admitted because of their diabetes. We want to facilitate good basic diabetes care. Getting the basics right is hugely important, and we want a project that's designed to upscale the non-specialists because we know that people with diabetes are in every ward in every hospital. The key focus for improvement is not earth-shattering. If we can get the basics right, if we can recognise people who have diabetes in hospital wards, that's hugely important, from getting their food given to them on time, getting their medications on time, checking the patient's feet. We want good blood glucose monitoring, we want appropriate blood glucose monitoring, and we want prevention and appropriate management of low blood glucose levels. We want safe management of insulin. Another key focus of this project is that we've integrated with the National Foot Care Programme, Foot CPR, which Duncan's going to speak to you about today. So what we want is for all these basics to be taught in undergraduate education. We have some measures for the programme. We wanted to ensure that every patient who had diabetes was identified on admission to hospital. We wanted to reduce insulin errors and make insulin prescribing safer. We wanted a reduction in the incidence of hypoglycaemia and improvement in resolution times, so when somebody has a low blood glucose level, they're treated appropriately. And we have some data to support this, which Scott is going to speak about. We have some resources which include things like these posters, and the Diabetes Think Check Act is a nice little cycle of care, thinking about the risks associated with diabetes, the checks that can be put into place, and the actions that can be taken to address or mitigate risk. So for people who are needing to be referred to the diabetes team, these are the people who have been admitted because of their diabetes, but also the people that are having problems with things like severe hypoglycemia, problems with their feet, problems with blood glucose control in hospital. There are some patients who may need referral to the diabetes team for specialist advice. We've tested out some referral processes, so there are Diabetes Think Check Act magnets available, so these are like little fridge magnets that can be attached to the pod, the patient's own medicine pod above their bed. They can be attached to the whiteboards in hospital wards. These are person dependent, so we need staff to buy in to put these fridge magnets in the right place. We have the referral guidance. We have within our toolkit, which has been developed, we have some referral forms in SBAR format. And there's also the possibility to electronically link patients who have diabetes, and Scott's going to tell us about how electronic systems have been linked to the Scottish Diabetes Register. We've looked at blood glucose monitoring. This is probably one of the key areas for all hospitals to demonstrate data and demonstrate quality of care. Almost all health boards in Scotland are either considering or already have connected blood glucose data. And in Glasgow and in Lothian and in Tayside, we've been able to look at the data from the blood glucose meters. And it's quite an eye-opener when you see the quality of care that's on offer, particularly with hypoglycemia and the improvement opportunities that we have. If we look at blood glucose monitoring, We're looking to prevent the risk of problems with high blood glucose levels, low blood glucose levels in hospital. So the target range is a little higher than we'd have at home. And staff need to know about the risks associated with high blood glucose levels and low blood glucose levels. So we want people to have their blood glucose levels checked on admission to hospital, whether or not they have diabetes or not, because we know that there's several people who are undiagnosed. We want more frequent blood glucose checking during acute illness, and some of the treatments in hospital cause problems with blood glucose levels, for example, people who are treated with steroid therapy. And these patients can be found all over the hospital in respiratory and oncology, hematology wards. So we need to raise the profile to reduce the risk of problems with blood glucose control with other treatments. We need staff educated to identify and reduce the harm, and for all nurses who take responsibility for blood glucose monitoring, they should be appropriately trained. We've done a lot of work on e-learning modules, and we have 5 e-learning modules under the Diabetes Think Check Act logo: getting the basics right, insulin administration, treatment and prevention of hypoglycaemia, and intravenous and subcutaneous insulin. These are very engaging little modules. They last about 20 minutes. They're nice and colourful, and we've had very good feedback. We've had good uptake of the modules in most health boards, but not all, and we can get the analytics and share these with you if required. In addition, we like to promote the CPR for feet e-learning module, and they are all available on LearnPro. We're done some work around insulin therapy and the safety of insulin therapy, and within the toolkit there are signposts to some insulin charts that are in use in NHS Scotland. We know that insulin is a potent drug, but it's essential for people with type 1 diabetes to keep them alive. It can cause harm if it's given in overdose, but equally it can cause harm if insulin omission occurs. And sadly, we still see inpatient emergencies with insulin omission leading to diabetic ketoacidosis, and these should be never events in your hospital. I'm going to hand over to Stuart now, and he's going to speak to you about some work that they did in insulin safety.
As Debbie mentioned, one of the key measures for Think Check Act initially was to reduce the amount of insulin errors in our test wards by 50%. And what was quite interesting to us was the fact that hospital reporting systems such as Datex weren't very rich with insulin-related incidences. However, when we went onto the wards, we found that the number of adverse events associated with insulin were really quite high. It is a challenge for improving insulin errors. One of the biggest successes that I think we had, which is shown in the run chart in front of you, was around actually the diabetes team physically going to the wards to do rapid cycle audits on various aspects of insulin management. I was involved with that. I found it a very rewarding experience because the vast majority of insulin prescribers in our hospital are foundation doctors. And I think it's fair to say that insulin does cause a lot of anxiety to the non-specialist, and actually having the ability to provide some real-time feedback while capture some data showing an improvement was actually very, very beneficial indeed. This was time-consuming, I'll make no bones about it, and did not run as smoothly from a data collection perspective as perhaps some of the hypoglycemia data that has been presented to you already, which is an automated process. But I think, to be fair to everyone in what has been required to improve insulin management, there has been some physical hands-on work which will be dependent on what local resource is available for that. And we have had a focus on hypoglycemia, making no apologies for that. We're able to capture hypoglycemia on our linked glucometer data. How do we define a correctly treated episode of hypoglycemia? Well, we use the glucose data for that because it's very difficult to capture specific treatments. But if you have a blood glucose reading that's less than 4, if you have a reading that is greater than 4 within 60 minutes, then we would count that as a successfully treated episode of hypoglycemia. The gold standard is that you should have it treated within 15 minutes with a repeat blood glucose at 15 minutes, but we took 60 minutes as an arbitrary cut-off. And colleagues in Glasgow, Chris Sainsbury has presented some work showing the average time to repeat glucose check, which really has been quite striking. It's well beyond the 60-minute interval. So with colleagues in Tayside Pharmaceuticals, hypoboxes are now available for purchase. The Scottish Government has pledged some resource into funding hypoboxes. Health boards such as Greater Glasgow and Clyde and Ayrshire and Arran are in the process of implementing the hypobox, and actually Greater Glasgow showed immediate improvements once the hypobox was available. And actually in our own work in Think Check Act, we started off with a baseline that 30 to 40% of hypoglycemic episodes were appropriately treated. However, through the use of making sure each ward had a hypobox and ensuring that ward staff were educated on the correct management of hypoglycemia, we quickly got that up to a successful management between 80 to 100% of cases. What was a challenge was whenever there was a change of staff or some bank staff use, which is reality in the NHS at the minute, that performance around management would drop. And again, this highlights the importance to us of maintaining that data flow towards to show them how the management is going, and when things have perhaps slipped, the refocus in improving that again. So the asks around hypoglycemia, the immediate asks would be to ensure that every acute ward does have a hypobox, to make sure every ward has the materials to treat a hypoglycemic episode when it happens. The e-learning is available. There's specific measurements in hypoglycemia, as Debbie has said, amongst other important areas of inpatient care. And perhaps one of the most simple rapid cycle audits would be identifying a ward who has a higher rate of hypoglycemia and seeing what numbers of staff have completed the online education with regards to hypoglycemia management. Although this is a program to emphasize the core diabetes management to non-specialists, we feel it's very important that there is engagement with your local diabetes specialist team. The ask of the boards have been to nominate a non-diabetes specialist, but it's important that your diabetes teams are involved. One of the biggest challenges is getting attendance at education sessions that are run by diabetes specialists. We've had that feedback from many health boards, and that's where the senior leadership and prioritisation of inpatient diabetes will be crucial, because many days are offered from inpatient specialist teams, but unfortunately the attendance is poor. And I really can't emphasise enough the power of data to drive change, both through the use of NADIA, which captures hypoglycemia as a measurement, but also through the linked glucometer work that has been presented already. So we have a toolkit. The toolkit is up and running. The link is on the bottom right-hand corner. This has links to the resources, to much of the material that you've seen today about implementing Think Check Act and other inpatient directives, which are from a diabetes perspective in Scotland. And I think in summary, our key findings would be that we have found challenges with implementation and improvement. Leadership and prioritisation is key, and I guess the prioritisation is why we're all sitting around tables and listening to WebExes today. This is a programme for non-diabetes specialists. This is not designed to make everybody an inpatient diabetes specialist. This is about getting non-specialists who really want to deliver good, solid core care to their patients, about getting everybody upskilled and ensuring optimising patient experience, but also getting some healthcare associated benefits around systems and flow. Data drives improvement, and undoubtedly there are efficiencies with improved inpatient diabetes care, and there is room for improvement in our Scottish hospitals. So if I had an immediate ask, or if we had an immediate ask, the immediate ask would be prioritisation of e-learning modules. These modules have been designed in the face-to-face education, as Debbie has said, that was delivered, but it was difficult when you went to a ward and there was a clinical emergency, all the staff that had been aligned for that education were clearly needed to be involved with somebody who was unwell. So the modules have been designed with what our busy healthcare professional colleagues, what they want and in a method of how they want to get it. The feedback has been excellent. Previously we had a completion rate of 30%. 30% completed the online diabetes education that we had. And we now have 15,000 module completions, which is way beyond what we had before. And NHS Wales have asked and will be using these modules soon, which I think was one of the most positive areas of feedback for us. We'd ask that you ensure, and if you don't, that how many of your acute wards have a hypo box, and if you don't have it, how many don't have it. So that's something that's to be implemented, relatively straightforward. And again, emphasising the importance of liaison with your local diabetes specialists. Because the local geography will be different, the requirements of each inter-health board will be very, very different depending on what's available locally, but close liaison with the diabetes team will help realise some of the potentials with this project. So I'm going to hand over to Duncan Stein, who's going to update us all on CPR for feet.